Dr. Erin Goldman is here to deliver an enlightening presentation on a medication, ELREXFIO, a treatment option for relapsed or refractory multiple myeloma. Dr. Goldman is a medical director with the Global Hematology Medical Affairs Group at Pfizer, where she focuses on multiple myeloma. With 15 years of experience in pharmaceuticals and biotech, her proudest work involves support of the safe and effective use of fiber medicines in rural and underserved communities. Please extend a warm welcome to Dr. Goldman.
Hello, everyone. Thank you so much for having me. I'm really happy to be here. I'm really honored. Thank you, Lynette, and all of the organizers for inviting me. And I'm going to talk today about multiple myeloma and also a new therapy that's available for multiple myeloma. So first, before we get into my talk too much, I want to give a little background on multiple myeloma. Multiple myeloma is a blood cancer. It affects cells, they're called plasma cells. So these are white blood cells, they're immune cells, and they make antibodies. So antibodies are the proteins that help fight disease, help fight infection, help fight anything that's foreign that comes into your body. So what happens with this cancer is that those cells, those immune cells, stop working properly. And then they grow and they kind of take over your immune system and they make bad antibodies, antibodies that don't work very well. So then your body cannot make good antibodies, and those bad antibodies get into your organs and they make it so that you're more likely to get sick because your immune system isn't working well. You're more likely to have problems with your bones because these cells are made in the bone marrow inside your bones, so that you can get destruction to your bones and your skeleton, and then also other organs because those bad antibodies get into your organs and cause problems in your organs. Multiple myeloma is more common in the Black community than in the white community. It's more common in the Black community than in any other racial or ethnic group. We don't know why that is. Potentially environmental factors, genetic factors, these are all things that are being studied. We don't know why. What we do know is that when Black patients get access to the same level of care as other groups of patients, they do just as well, if not better, on those therapies. So I think that emphasizes, it's very clear that access to the right care is important for all Americans, and that's something that we all need to focus on. Both, I represent Pfizer, the pharmaceutical community, the healthcare community, advocacy groups. This is something that we all need to focus on and spend more money looking at and investigating. So I'm going to give you a little bit of information. I don't see my slides anymore, but oh, they're still up there. Oh, thanks. So I'm going to give you a little bit of information about a new drug that we developed at Pfizer to treat multiple myeloma. And I don't think I introduced my role at Pfizer, so I'm a medical director, which means I am involved in helping to develop drugs. I'm involved in the design and the run of clinical trials to try to get new drugs to patients. And this new drug called ELREXFIO was just approved here in the United States in August. Oh, thanks. Thank you. Yes, we're really proud that it was approved here, and we think it's a really big step forward for the treatment of multiple myeloma, and I'm going to tell you why in a little bit. So first, there are a lot of legal things that we have to do as a pharmaceutical company when we talk about drugs. One of them is that we have to talk about what it was approved for, because it's really important that we support the use of the drug the way it's supposed to be used, and not in ways that we haven't tested it yet. So this is a statement about what ELREXFIO was approved for. And it is approved for adult patients, so everyone on our study, on our clinical trial that led to the approval of the drug was 18 years or older. So we don't know anything about this drug in patients. But with all of our drugs, hopefully down the line, we can test this drug potentially in children, although multiple myeloma is very, very uncommon in younger people. So the median age of multiple myeloma is 67 years old. So typically it's uncommon even in people in their 30s and 40s. Although the incidence, the levels of the disease in younger patients is rising, and that's another reason that we don't understand why that is. But typically this is a disease of people in their 60s, 70s, and 80s. And it's approved in later lines of therapy. So the patients on our study had already had at least 4 other therapies, and those therapies had failed them. So these patients, their disease was coming back after those therapies had failed them. And this is common in cancer. When we test new drugs, we typically will test them in groups of patients who have had prior therapies, and those therapies have failed them. And the reason why is because in order to get those drugs to patients as quickly as possible, we try to go to the area of the highest unmet need, because these are patients really where they don't have any other treatment options at this point. So it's important to get the therapies to them the quickest. We have other trials that are currently ongoing, where we're looking at our drug in patients who have had less treatments, so in earlier lines of therapy now. And we hope that patients will be able to benefit from this drug even earlier. This is all important safety information. Again, this all has to be up here legally. I'm not going to read it all because I'm going to talk about some of the side effects of this drug later when I talk about the drug a little bit more. I will keep it on the screen, and if anyone wants to take screenshots, this is also all available online. Happy to send it to you, but I could spend the whole time, instead of talking to you, reading all of this safety information. So I'm just gonna, I don't want to go through it too quickly, but this is our important safety information. And I'm going to go through many of these slides very quickly. This is a wonderful audience. This talk is really intended for doctors, for oncologists who treat this disease. And so that's why I'm not using the slides very much, because I think the slides have some interesting information, but I'm going to try to really talk to you about kind of what we did and what the research program is and what this drug can do without relying on these slides too much. So first, the history of myeloma treatments. So you can see that there are a lot of treatments now available for multiple myeloma. And you can see that most of these became available in the past 10 to 20 years, and in fact, many of them in the past 5 years. This is an area of research that's developing very, very quickly. When you look back in the 1960s, if you were diagnosed with multiple myeloma, the only thing that was available to treat it was melphalan, which is a standard chemotherapy drug, and prednisone, which is a steroid. At that time, outcomes were not very good. So if you were diagnosed with multiple myeloma, most likely within a year or so, you would not survive past a year. With all of the new treatments, those outcomes are getting better and better and better. So now we have groups of patients in patient advocacy groups who have lived with this disease for 20 years or more. The median survival, so the sort of average survival right now, is about 5 years, but that's growing every year. It gets longer and longer and longer. And there are many patients who are on the tail end of that curve who are doing much, much better. And really that has to do with the availability of all of these kinds of therapies. And all of the therapies that are more recent are more targeted therapies. So rather than, in the 1960s where it was just chemotherapy, which was just kind of attacking any quickly growing cell in the body, these new therapies are really attacking specific things in the myeloma cells, so specific things in that cancer, so that you can kill the myeloma cell, destroy that cancer cell without destroying all the organs and the healthy cell around them. So that's the goal. Of course, every drug has side effects, but these drugs are able to work better because they're more targeted toward the cancer versus other cells. So now I'm going to tell you a little bit about ELREXFIO, the drug that we developed and was just approved this summer. So some interesting things about it, it's ready to use. It is an injection, it's a shot. It's typically given in the stomach area. And the reason why that's important is because many of the drugs, ELREXFIO is what's called an immunotherapy, so it uses your body's own immune system to try to fight cancer. And many of the drugs in this space are not readily available. They have to be manufactured sort of to certain specifications that can only happen after you're diagnosed. So there's a delay in when you can get them, whereas ELREXFIO can be given right away. And this slide describes what ELREXFIO is. What it is it is itself an antibody. So this is an antibody just like the ones you have in your body, but this one is manufactured in a laboratory. And antibodies have two arms, typically. And so what ELREXFIO has is one arm that binds to the cancer cell and one arm that binds to T cells, to immune cells. So it takes those immune cells and brings it to the cancer cell, and then your own body's immune cell destroys the cancer cell. So this is our study. I'm not going to go into too many of the details of this study, but the study was done in 123 patients overall. And as I told you before, these patients were heavily pretreated. So they had a lot of prior therapies. The median age was about 65, so they were a little bit younger than the typical multiple myeloma patient, but not too much younger. And these are the results of that study. So you can see that almost 60% of patients had some kind of response, which means they had a decrease in the level of cancer in their body. And just to kind of put this in context, some of the earlier therapies that I was telling you about at this stage of disease, so when patients have already gone through multiple rounds of treatment, the response rates that you're sort of typically seeing with old therapies would be maybe around 20%. 30%. So this is a huge step forward. And not only our drug, ELREXFIO, but some of the other newer immunotherapies are also showing this level of response. So it's a huge step forward in the treatment of this disease. And what we hope is that, and we're looking at that now, that we may see even better results if we bring it earlier, if we can get it to patients before 4 therapies have already failed them. You can see also these responses are deep. So complete response is when, by most measures, how you measure the disease, you can't detect it anymore. And you can see that about a quarter of the patients had complete response. So by the typical measures that you look at this disease, we're no longer detecting the disease. Over half of them had better than very good partial response, which is a particular definition in the treatment of multiple myeloma, but essentially what it means is that there's low levels of disease. We can detect it, but it's quite low. And that level of response is considered clinically meaningful, because that's when people can really they feel better. They can get back to their normal activities. They can go back to work. They can play with their kids. They can go on trips. They can exercise. That's a big thing, because multiple myeloma affects the bones and it can affect the nerves. And so when you feel better like that, it allows people to really get back to normal activities. Also, really importantly, these results are durable. So what I'm showing you here is at 9 months of follow-up. So we gave the drug to patients, then we looked 9 months later, and at that point, over 80% of the patients still were maintaining that response. We have even longer follow-up, and we are now seeing, that level of response seems to persist even longer. So that's really important too, because it's nice to have a deep response, but if it only lasts for a week or two, then you're putting a patient through a lot for something that's not benefiting them long term. So that was something that was really important for us to see, not only those levels of response, but that durability of response. Another important thing is that the responses happen quickly. So most patients responded within about a month. Again, that's very important, and particularly in this patient population, because we have a population of patients who, again, 4 therapies had already failed them. So they need a response quickly because their disease is quite advanced, and it will cause further damage to them and their body and their healthy organs if it's not contained very quickly. I'm going to skip some of these and So these, what I'm showing you right now, there were 2 different groups in the study. One group had already had a therapy similar to this therapy, and one group hadn't. The results that are on these slides are in the patients who had already had a prior therapy that was like this, and they also did very well, but I'm not going to go through all of that. I do want to go over the side effects a little bit because I think that's really important. The most common side effect with this drug is called cytokine release syndrome. And what that is, it's the immune system overreacts. So this drug is an immune therapy. It's meant to stimulate the immune system. But sometimes, and this happens early in therapy, a patient will get the drug and their immune system goes a little bit crazy. So they get a lot of inflammation, they can get fever, they can get hypotension, so their blood pressure can go down. And if it progresses too far, then they can have difficulty breathing. They may have to go into the hospital. So those are all serious things. It can be managed, but it needs to be recognized and understood so that it's managed properly and managed right at the beginning of therapy, because that's when it occurs. It goes away because it's really just the body reacting to the first exposure to this immunotherapy, and then it tends to calm down after that, after those first couple of doses. So we did a few things to try to decrease the risk for that particular side effect. One was pre-treatment medication. So every patient who came on got essentially Tylenol, Benadryl, and a steroid just before those first couple of doses, just to make sure that their body didn't, or try to minimize the risk for that kind of immune reaction. And then we also did step-up dosing. So the first 2 doses were much smaller doses than the dose that the patient eventually takes for the long term. And that's, again, just to expose the body to a much less extent to try to minimize that really overactivation of the immune system. So you can see, as I said, this cytokine release syndrome, it was quite common. So it occurred in about half of patients, but what we found was we only saw lower levels of it, so grade 1 or 2. These grades are a standard way that you measure how serious a side effect is, and so any drug that's tested, you'll look at any side effect, and it can be grade 1, grade 2, grade 3, grade 4. So when we're talking about this cytokine release syndrome, grade 3 or 4 is you're in the ICU, and it can be very, very serious. Grade 1 or 2, grade 1 is a fever. Grade 2 is a fever, usually with some decrease in blood pressure. And so you definitely want to manage that grade 1 or 2 so you never get to the grade 3, 4. And we were able to do that in that study. So there was one patient who had a grade 3 adverse CRS event, but the others were all grade 1 or 2. So they were managed, and they were all able to stay on the drug, so no patient had to get off of the drug because of it. And they happened early, so at about 2 days after getting the first drug, and they were fairly short for the most part, so it also lasted about 2 days. So again, this is, it's a serious side effect that needs to be understood and managed very well, but if it's managed very well, patients can stay on the drug and benefit from it. There's a similar effect called ICANS. It's much less common. We saw it in our study in about 3% of patients. It's a similar cause. It's just the immune system getting overly activated. It usually occurs in patients who also have CRS, that first thing I was telling you about. But in this case, it affects the brain because you can get inflammation in the brain. And so typically, if it's not very serious, then what happens is the patient maybe gets confused, has a headache, and it's managed with steroids. So again, it's one of those things where it needs to be recognized. There's a questionnaire that anyone who gives the drug has and will give to a patient. when they have that CRS, to make sure that they don't have ICANS. And again, ICANS, those 3% of patients who had it, none of them had to get off of the drug, but they did have to be managed with steroids. So it's something that needs to be looked for. So other possible side effects, infection. Infection is common on patients being treated with ELREXFIO. Infection is common in general in patients with multiple myeloma because multiple myeloma is a blood cancer. So it's a cancer of the immune system, and the immune system in those patients doesn't work properly. So patients with multiple myeloma already are at risk for infection. We see even higher rates of infection with ELREXFIO. And that's probably because it is an immune therapy, so it works with your immune system, and your immune system can kind of get tired out. So that's something that we have to be very careful of. Also, we ran the study during COVID, so we did have very high incidence of COVID in the study. So now when we give this drug, we have a number of recommendations about giving other drugs, for instance, making sure vaccines are up to date before a patient goes on our drug. Making sure, in a lot of ways, because we know a lot of these patients get viral infections, particularly respiratory infections, and especially this time of year. So we recommend that they get prophylaxis. They get drugs, antiviral drugs that they have in their system before they even get this drug, so that hopefully that will reduce any risk of infection that they may have. And there are other side effects. Similarly, with any drug, there can be diarrhea, nausea, injection site reactions. So when you inject that needle, sometimes people have a reaction to that. And there's also things like you can have liver problems. That happens often, with these types of agents. So I think I'll leave it at that. One thing that I do. Maybe I do want to show you actually this, and and then I'll put up the QR codes too. So we have something that we've created at Pfizer, and it's very new for this drug, where we have a group of people who are employed by Pfizer, and they're called patient access navigators. Because we know that this is a complicated kind of medicine, it's a new kind of medicine, and it has this new way that it works with the immune system. A lot of people just aren't familiar with how to use it correctly, and so we have a group of people called patient access navigators that you can call. There's a number there, and there's also a website. And they help with a bunch of logistics of getting the drug, where you can get it, because right now you can't get it everywhere. Also, how you can go there potentially and get it, and then go back to your regular oncologist, the person you're most comfortable seeing. They also help with cost, with affording the drug. So helping to find ways to help pay for the drug, and even if you have private insurance, help navigating that insurance quagmire that can be there. If you don't have private insurance, then finding other sources, including Pfizer-sponsored sources, to pay for the drug. So that's a fantastic resource that's really new, that we're just introducing, that it's a person. Because I think what we found is, yes, there's websites, there's numbers that you can call, but if you don't have a person who's helping you navigate this really complicated system, then it doesn't help a lot of people. So that's something we're also really proud of with this drug. And again, it's really about increasing access to a really important medicine, because there's no point in creating great medicines if the people who need them don't get them. So these are QR codes if you want to go to the website, or the QR code for that patient access navigator. Please, take those down and visit those sites. And now I'd be happy to take questions from the audience. Yes.
Who has a question? Okay, I'll start with somebody that's close by.
Hi, I enjoyed your talk.
Hi, thank you.
The patients that start on it, are they typically started in the hospital? And if so, what's the typical time that they can leave to go back as an outpatient?
Yeah, great question. They are right now. So because this is a new drug, how we designed the trial is that the first 2 doses are given within a hospital. So they typically stay about 5 days. And the reason for that is to really watch out for those things I was telling you about, like the CRS, that cytokine release. We are hoping eventually to move this where you wouldn't necessarily have to stay in the hospital at the beginning, but as we're trying to learn more about this drug, because it is a new drug, we want patients to be as safe as possible. So they're typically in the hospital about 5 days.
Yes. How long was this in clinical trials, and where was the location of the study site, and did it receive accelerated approval?
Yes, great questions, all great questions. Yes, great questions. So the first patient was treated in 2017, and the drug was approved in 2023. And so that's we did get accelerated approval. It was a very accelerated timeline, and when I say 2017, that was first in patient, so that was the phase 1. When we saw those early results, we knew that this had to happen quickly because we were seeing things that were very, very exciting and very promising. So everything moved very, very quickly. We did get accelerated approval. The sites were all over the world. So there were 2 sites here in Atlanta. Emory had the study, and also Northside had the study, but all over the world.
What was the diversity of the study?
Yeah.
And also, the treatment where you had about 60% success rate, what's the duration of time that they had to take the medicine, and were they off of the medicine at that time? And the prolonged improvement of about 82%, were they taking the medicine at that time as well?
Fantastic questions. These questions are really great. The diversity of the study was not as good as we would like, to be honest with you. So we had a diversity goal. Our goal was to recruit 20% of Black patients. We did not meet that goal, so we had 7% of the patients were Black. The reason for that is that as we were trying to move this study very quickly, we started accruing outside of the United States. And so it's very difficult in many of these countries to get very diverse populations. We really rely on the United States to recruit Black patients. And by the time the study had come to the United States, it was almost fully accrued. So we have another ongoing study that's actually specifically focused on Black patients. And we have a recruitment focus in the United States that we're opening early, so we hope to see more. We have analyzed the results in the Black patients that we did have on the study, and they did exceptionally well, just as well as the entire population. So, we intend to confirm this with a larger study with more Black patients, but we really are hopeful that this drug is going to be just as good an option. In terms of being on the drug, that's a really great point, because we all know in these patients, they want to get off these drugs as soon as possible. So right now, the way this drug is approved is that you get it every week. You get an injection every week for 6 months. After 6 months, if you have a response and that response is sustained, you move to every 2 weeks. If that continues for 6 months, you go to once a month. We are starting to look at how long, if the drug can be discontinued entirely. The answer to your question, we had a number of patients who got off drug for one reason or another. Either they had a side effect that they didn't like, and what we saw, interestingly, was that in many of those patients, a majority of those patients, they continued to respond for a long time after they got off the drug, which is something you might expect. If an immune therapy is working properly, then it's kind of changing how your body itself is fighting the cancer. And so your question is spot on, because that's what we're looking at now, is how far can we stretch when the patient gets the drug. We want to stretch it as long as possible, and maybe even have a fixed duration, so the patient could be on for a year at those intervals and then maybe stop. But we're trying to look at that now and see, well, when would you restart, say, if their disease came back? All of those questions are really important research questions that we're looking into.
Thank you for the responses thus far. I wanted to just acknowledge that my father passed away from multiple myeloma.
Sorry.
But I also wanted to acknowledge that the VA and veterans of the Vietnam War typically are diagnosed with this because of the environmental. So I would implore you to potentially work in coordination with the VA or other programs that have a base, if you will, for recipients to participate. So, and of course, the National Medical Association. So we need to work together when you say you can't find persons of color to be participants.
100%. And, you know, there is unfortunately, it's very difficult, if not impossible, to run clinical trials at the VA, just because of the structures of the government institution in that way. But your point is 100% taken, and we have an entire group at Pfizer. It's the Diversity Center of Excellence in Clinical Trials, and it's the whole remit of that group is that we need more diverse trials. And I think part of it too is overcoming some of the historical reticence because of some, you know, really bad things that have happened in the past in terms of, you know, clinical trials. And so I think that's why we're trying to work with groups like this and local community church leaders to really encourage participation in trials also, because it benefits both the patient and the community.
Awesome. We have one
Thank you for
last
that
question.
Interesting presentation. Thank you very much. I just wanted to ask if you have any idea, can you tell us what kind of symptoms a patient might have? I know that you say you don't know what actually causes it,
Yeah.
but what kind of things might a patient or other diseases might they be, you know, symptoms that they might have that they themselves might suspect? Otherwise, it's left totally up to the physician one day to say, you have multiple myeloma.
Yes. That's a fantastic point. And, you know, part of the issue is multiple myeloma is a relatively rare disease. So in a group of 100,000 black people, 16 of them will be diagnosed with multiple myeloma this year. So it is still relatively rare. So a general practitioner may not be looking for it or thinking about it. What I would say, and it is often diagnosed through symptoms, because there's not routine screening, and you wouldn't typically do routine screening. There are tests you can do, but you just typically wouldn't do them because it is a rare disease. So you're not necessarily going to do, you know, a bone marrow aspirate on every patient, because that's quite painful and, you know, has its own risks. So what I would say is extreme fatigue, you know, which is true of any cancer, but extreme fatigue, bone pain. So if you're feeling a lot of bone pain, and especially if it seems new, you haven't felt it before, very easy bone breakage. So if you kind of have a minor fall and you break a bone, that, you know, talk to your doctor about it. Say that this may be more than just, you know, me falling down, and, you know, I shouldn't have broken my wrist from, you know, just this minor fall. So I think those are the main sort of just clinical symptoms. But I think also it's, you know, if you're just not getting better, you know, we hear this again and again, particularly from black patients, that they're just not heard. And so just really say, no, I know how I feel. I know how my body is supposed to feel. Also peripheral neuropathy. So if you start to feel like numbness in your limbs, in your fingers, in your toes, and it's not going away, just keep asking, say, you know, what about multiple myeloma? You know, because the tests you can do blood tests that can give you a sense of whether you have it. You can do sort of scanning, so x-rays, MRIs. All of those will show you if you have multiple myeloma, but they're just not routinely done. So just keep, you know, demanding if you have some of those bone issues, nerve issues that just don't seem to be getting better.